endometriosis, by definition, is the growth of tissue similar to endometrium outside the uterus. And therefore, removal of the uterus is not a treatment for endometriosis.
Hi, welcome back to the channel. My name is Melissa and I'm talking with Dr. Shaheen Khazali about endometriosis and UTI. This is part 2 of the interview and we'll be discussing diagnosis of endometriosis and treatment options. Be sure to check out part 1 for more information about what endometriosis is and symptoms. If you're new to the channel, be sure to check out the description below as we've linked to some resources you might find helpful. And lastly, if you enjoy these videos, think they're important and want to support what we do, be sure to hit subscribe and check the bell so you'll be notified of any new videos we post. And other than that, thanks again for joining us on this journey to making change in women's health. This is part 2 of our interview with Dr. Shaheen Khazali on endometriosis and urinary symptoms. Thanks again for joining me for this chat.
Thank you for having me.
I wanted to jump into some questions about diagnosis of endometriosis. What is the most accurate way to diagnose it?
It depends on the type of endometriosis. For example, endometriomas can very easily be diagnosed with a simple ultrasound scan. I mean, even in inexperienced hands of ultrasonographer, an endometrioma is obvious, it's very easy to pick up. It's much more difficult when we're dealing with superficial endometriosis. Still, with superficial endometriosis, ultrasound scan can sometimes help, giving us clues that we may be dealing with endometriosis. But ultimately, being able to see the inside of the pelvis and the abdomen is the most accurate way. And for many years, it was called the gold standard of diagnosis of endometriosis.
And when you say see, you mean surgery?
I mean surgery, I mean laparoscopy, yes.
And so what should someone do if they have had an ultrasound and it has come back clear? Is there a natural escalation before you get to that point of laparoscopy?
Yeah. So I believe my colleagues do things, perhaps, every one of my colleagues may be doing things differently. My way of approaching a patient that comes to me with pelvic pain and no diagnosis is that I start with a baseline likelihood of endometriosis. So a person doing shopping on the street has around 10% in that age bracket between 15 and 49, has around 10% likelihood of having endometriosis. As soon as they are in my clinic, that likelihood is probably tripled.
Okay.
So if somebody has come to see me, it's not a social call. They've taken time out and they've made the effort to come and sit in my clinic. So that immediately puts them in the bracket of having more likelihood of having endometriosis. But then what I do is I put all the different clues that I get, and ultrasound is one of them, not the most significant one, not the most important one, only one of many. Perhaps the most important one is the patient's story and the history. Okay, so I listen to the character of the pain, the relationships of the pain with different things that happen in the person's lives. When did it start? What is the pain like? What's its intensity? Is there any pain with defecation? Is there any pain with sex? And each of these will be a piece in that puzzle. And then I examine the patient, and that will give us a lot of information as well about what the likelihood of endometriosis is. So sometimes we need further tests like an MRI. Sometimes we need a more specialized ultrasound scan. And I put all of that together and then come up with some likelihood of or estimate of likelihood that this patient in front of me would have endometriosis. And then we use that likelihood for decision making on what to do next to get to the diagnosis.
Right. And what's your advice for a patient who suspects they have endometriosis but is having trouble moving that conversation forward with their own doctor?
I would suggest that we imagine we are the doctor. And then that would give us a clue to how to approach it and how we would win with our doctor. And I don't want to take sides here, but the reality is that I don't think any doctor gets up in the morning wanting not to be helpful to their patients. So they are there to help. They want to help. But there are a few numbers that perhaps will be useful to remember. 7 out of 10 women will have painful periods. One of these have endometriosis. So if we were to do a laparoscopy on everyone who has painful periods, we would be doing 6 completely pointless laparoscopies, and that comes with all sorts of problems. The cost is one, but the least important one. The risk of complications, the risk of adhesion formations, and all the rest of it. So the key is to find maybe not that one person who really needs the laparoscopy, but maybe bring that 7 down to maybe 2 or 3, and then do the laparoscopy on those. But it's very difficult for a general practitioner who has 10 minutes to talk to a patient and sees many, many patients who come to them with pelvic pain, and is not a gynecologist, is not an endometriosis specialist, to be able to do that. So naturally, for them, the logical thing to do is to say, well, it's probably nothing. Go away and have this medication, or have this hormone. Maybe that will get better, or have this ultrasound scan. My advice is that don't get the conversation to a point that it feels like that you are sitting on 2 opposite sides of the table. The reality is it's a partnership. Okay, so need to explore where the problem is. Is it that your doctor is not believing you and thinks that you're making it up and you just want to take a sick note? Is that the problem? Is it that they just are not confident in this area and maybe you need to see another doctor who is more confident? Or is it simply because they are doing their best and maybe it's not illogical what they're suggesting, that maybe, if your pain only started 2 months ago and you haven't tried anything, maybe it would be right to first try simple things first. That would be my advice. And my experience, although I'm perhaps it's difficult for me to say because I'm sort of the final stop for most of the patients, that they are seeing me because they've seen others, or their gynecologist have recommended that they need to come and see me because their operation is too complex, or their GP knows that they need to see me because they have endometriosis. But if you're seeing a general gynecologist, for example, sometimes the right thing to do is to be very frank and very direct and say, what else can we do to get to the bottom of it and to get to a diagnosis, and explain that even a negative diagnosis would be valuable to you. And again, remember, as I said at the beginning of the answer, that with some very few exceptions, they're all there to help, and they are all they're all doing their best to help.
What is currently the time to diagnosis for endometriosis?
Around 8 years in the UK. I heard some very exciting news. I just came back from Lisbon. I was at a conference lecturing in Lisbon, European Society of Gynecological, and I heard a very interesting talk about a very promising method for biomarkers and diagnosis of endometriosis, which I've listened to many of these types of talks, but this one was different. So they are using a technique similar to how the COVID vaccine was developed and using artificial intelligence to try and pinpoint what set of biomarkers we can look at to pick up endometriosis early.
Will this be a blood test?
Yes.
That is very exciting.
Well, yeah, it's even more exciting than that because they're now looking at saliva tests as well. So it's a messenger RNA that they're looking at that is also excreted in the saliva. So I don't know, you may spit into a tube tomorrow and be able to get a diagnosis of endometriosis. That would be exciting.
Do they have any information about when this might be on the market?
It's early stages.
Okay.
It's very early stages. I would be very surprised if it will come out in the next 2, 3, 4 years. I would be very excited if it does, but you know, I don't know.
Yeah, it would be a game changer, I'm sure, for a lot of patients. So once a patient has their diagnosis, what is the gold standard for treatment of endometriosis?
There is no one size fits all. It's considering what the main problem is that the patient is trying to solve. You know, for some, they only want reassurance that there is nothing wrong, there is nothing serious. For some, fertility is the main issue. For others, pain is the main issue. For others, pain during sex is very important. For some, it may not be important at all. So we need to tailor the treatment to each individual's expectations, their main issues, their understanding of the whole story. And the philosophy of care is that we use the least aggressive method, the least invasive method that achieves the result that we want. So endometriosis diagnosis doesn't equal needing surgery. For some, doing nothing may be enough. For others, medical treatment may be suitable. And for some, it may be surgery.
When it comes to surgery, can you explain the difference between excision and ablation and why excision is usually the preferred approach?
Yes. So ablation is applying heat of some sort to the endometriosis lesions. So sometimes it's diathermy, sometimes it's laser, sometimes it's something called helica or plasma jet. It comes in all sorts of different names. But the essence is that the surgeon will apply some heat to the lesion that they see. And that may be okay if we're dealing with truly very superficial disease and we're using something like laser that evaporates the whole of that layer. But the problem is, in most cases, the disease is deeper than what we can see. And therefore, again, today I can give you examples from my today's clinic about all your questions. You know, a patient who had surgery only a year ago, and I can see the pictures, she had ablation. That's probably 30% of my practice is patients who've had ablation multiple times. The record has been 58 laparoscopies that I saw in a patient just a few weeks ago. That was something else. Anyway, so this patient had surgery in October, and the surgeon had ablated the disease, meaning they applied diathermy. You look at the pictures and you can clearly see that these are deep endometriotic lesions. She got better. The pain went away for 4 or 5 months, but now it's come back even worse than before. And this is a very typical picture that I see all the time. That that any surgery, ablation, or just diagnostic laparoscopy often helps with pain for a few months. We don't understand why. It may be placebo effect, or it may be a true effect of some sort because of the distension of the peritoneum. And so that's ablation. Excision is when we cut away the abnormal area. But excision is a much more challenging thing to do. It requires a particular set of skills. It needs training. It needs patience. It needs time. So a typical laparoscopy for ablation of endometriosis may take, 10 minutes to do. But excision of the same disease may take 2 hours, an hour and a half to do. So, and also that would require you knowing the anatomy of that area very well and being able to separate the vital structures from the disease and then cut away the disease. And that's called excision.
Okay. Is that used when you have this deep infiltrated endometriosis that might be going through the bladder wall?
That's one scenario in which it is used, but in my practice, I excise any endometriosis that I see, even if it's superficial, because I believe I can't be 100% certain that this is superficial. And also, I worry about skip lesions between the little lesions of endometriosis.
In how many patients, or what percentage of patients do organs need to be resected or removed?
Oh, it's a small percentage. Although, again, my practice is a bit unusual because I operate on those who need that kind of operations because they've been referred to me for that. But let's go back to the definition of endometriosis and then go to organs one by one. So endometriosis, by definition, is the growth of tissue similar to endometrium outside the uterus, and therefore removal of the uterus is not a treatment for endometriosis. So if by organ, let's start from the uterus. Removal of uterus is not part of endometriosis treatment. The only caveat is that endometriosis and adenomyosis can coexist often. And if you do have adenomyosis in a patient who has completed their family or have also bleeding problems or have multiple fibroids, then it makes sense to remove the uterus at the same time during the operation. So that's one organ. Bladder, we never remove the organ, but we do something called a partial cystectomy. Again, I can give you an example of my patient today, where endometriosis has grown inside the bladder. She is going to need part of the bladder removed because the disease has come through the wall of the bladder and is actually visible when we look from the inside of the bladder at cystoscopy. We can see it. So these are uncommon. Again, in my practice, I see a lot of them, but generally speaking, they are around 1% of all endometriosis patients. Bowel endometriosis is a bit more common than that. So bowel endometriosis is up to 10% of endometriosis. But again, the difficulty is we have different definitions of bowel endometriosis. So I call bowel endometriosis that when it has gone inside the muscle of the bowel, not if it's just sitting on the surface of the bowel.
Right.
So in a small percentage of those, when endometriosis has completely invaded into the muscle of the bowel, then we need to remove that part of bowel if the symptoms are significant. Same with the ureter. If the disease has gone into the ureter or is compressing the ureter in a way that we can't really separate it from it, then we need to remove either part of that ureter or cut the ureter before the area of obstruction and implant the ureter into the bladder.
Okay. What are the potential consequences of not removing all the endometriosis in those cases?
It very much depends on the circumstances. We need to remember endometriosis is not cancer. So it's the aim of treatment is to give the patient her quality of life back. And if we have done an operation, we thought we were complete, and the patient is much better and the pain is gone, whether or not they have some microscopic endometriosis left somewhere matters less. But the problem is when we do incomplete operations, when we know we have done an incomplete operation, and that's the issue. So, for example, going to remove endometriosis, and we see that we're dealing with a full thickness bowel endometriosis, but we just leave that, which in some circumstances is the right thing to do. Then that disease can grow. First of all, the symptoms don't get better, and also the disease can grow further and further, and it can cause bigger problems. So something that could have been dealt with by a smaller operation now needs a much bigger operation to be sorted.
When you do have patients where it does involve the bowel or the urinary tract, do you then have a gastroenterologist or a urologist on the surgical team?
Yes, not a gastroenterologist, a colorectal surgeon.
Okay.
So again, it depends. If I need to remove part of a urinary tract, particularly on the ureter, or if I need to do a segmental bowel resection, then I do have a urologist or a colorectal surgeon, or sometimes a transplant surgeon. But if the disease is sitting on top, then I deal with that myself. In the UK, we tend to involve everyone in the surgery, even though you can do the operation on your own, but it's preferable to bring your friend in and do the operation together. We call it a multidisciplinary team treatment. We sometimes use a transplant surgeon when I do reimplantation of the ureter into the bladder. And that is because those transplant surgeons are very skilled in putting ureters into bladders, because that's what they need to do when they do kidney transplants. But they often are not laparoscopic surgeons or robotic surgeons. So the arrangement we have is that they are there to make sure that I'm doing a good job. And the agreement is, if at any point they feel that actually this will be better if they took over and opened, that has never happened so far.
Okay.
They will do that. So we put the patient at the center of all of this and do what's right for the patient.
Okay. And if the excision has been fairly comprehensive, what are the chances someone might need a repeat surgery later?
The numbers that have been quoted are widely varied. I'm looking at my own numbers. So we are looking at my outcomes of 10 years. I started October 2011. So we are coming up to 11 years now. And it looks like, just a very rough count, it looks like that I've operated on less than 5% of my patients more than once.
Okay.
Maybe even less. I'm just being very pessimistic with that number. And often when I've operated on them, it has been to do something else, not to do the same thing. For example, we tried to see if we can get away without doing a hysterectomy in a patient who also had adenomyosis, and we did the operation to excise the endometriosis. She's not better, then we go back and do the hysterectomy. But yes, endometriosis can recur, and sometimes we need to do operations more than once.
Okay. And do you ever find among your patients that the surgery has an impact on the menstrual cycle or on their hormonal balance or their libido?
Yes, but not all of those are a direct relationship. So for example, if sex hurts less, because I've removed the endometriosis, then it's likely that your libido will improve. Because if it hurts, you're not going to want to have sex, and therefore, that's the way it works. Bleeding, yes, there is an interesting relationship between the type of bleeding, the amount of bleeding, and endometriosis. A lot of it we still don't understand. We have always thought that the abnormal bleeding comes from the adenomyosis rather than endometriosis, but actually it looks like that endometriosis, the presence of endometriosis itself, could impact bleeding.
Okay. And for patients who had urinary symptoms prior to surgery, do you find that for many of those, the symptoms subside post-surgery?
Depends on the type of endometriosis they had, but yes, very often, yes. So if you've had even superficial endometriosis on the surface of the bladder, on what we call uterovesical fold, often the pain will disappear completely. In those who had deeper disease, it's even more likely that surgery will completely get rid of their pain. Sometimes that would then come with other symptoms that would be new after surgery, but often they will feel a lot better.
Okay. And a question about hormonal replacement therapy. Is it safe for people with endometriosis to use that, or vaginal estrogen therapy?
Yes, it is safe. With those with endometriosis, we tend to suggest that they go on a combined preparation for HRT if they need HRT, of course. If you don't need it, don't take it, of course. But if you need HRT, then having had endometriosis or having endometriosis is not a contraindication.
Okay. And speaking of medications, are there any medications that can treat endometriosis, or are they mostly geared towards relieving symptoms?
Well, that is a treatment. Relieving symptoms is a treatment. So if by treatment you mean taking away endometriosis or getting rid of endometriosis, we know that some medications will reduce the size of endometriotic lesions, including the size of the endometriomas. But there is no reason to believe that any medication can actually take away and get rid of endometriosis altogether.
What percentage of patients do you think do benefit from symptom relief when they go on oral contraceptives?
Oh, a lot. So something around 60% of patients with pelvic pain and period pain will see significant improvement in their symptoms when they go on hormonal treatment.
Okay. And for people that do experience pelvic pain of some type and have not been diagnosed with endometriosis, but then take an oral contraceptive and feel better, could that be an indication that endometriosis is present?
No. We have something called primary dysmenorrhea. So we doctors have the habit of just hearing the patient's story and then giving it a Latin name and giving it back as a diagnosis. So primary dysmenorrhea means your periods hurt and I don't know why. And primary dysmenorrhea will get better with the pill because it stops the periods, or it takes away the natural cyclicity of the periods. So those patients will get better without having endometriosis. What hormones do, they just take away the natural cyclicity of hormones. That's all they do.
Okay, that makes sense. There was one more question. A lot of people in this community are on long-term antibiotics for recurrent or chronic UTI. Do you think that could have a detrimental impact on endometriosis given the possible association with the microbiome, or for any other reason?
I'm not aware of the association. If there is, I don't know about it. It's a long shot, I think, that, okay, if we accept that we have a direct relationship between microbiome and endometriosis, and then we accept that we have a direct relationship between long-term antibiotics and those particular, microbes that would be relevant to endometriosis. But it's possible. With endometriosis, we never say never.
Yeah, I think that's probably the right approach. There was one more question actually. That was whether there are any natural supplements that can help relieve the symptoms of endometriosis.
You know, I used to be a militant anti-supplement person. I'm less so now. I draw the line at homeopathy, though. You know, homeopathy is nonsense, and I would encourage anyone who's on homeopathic medications, even if they feel it's helping, to throw it away, because it's just feeding, you know, pseudoscience. But apart from that, if something that you're taking is helping you, then maybe. I've learned to now say, I don't know what the relationship between this particular supplement and you getting better might be, but I can't say there is none. And there are some supplements that have been suggested to be effective, but none of the research has been conclusive. So Chinese medicine treatments have been looked at, and we haven't found any benefit. The bottom line is most supplements are unlikely to do any significant harm apart from to your pockets. Right. So if you find something that is helpful, then go for it.
Okay, good advice. Do you work with patients in the UK and international patients?
Yes, I see a significant number of international patients, and they come to see me not necessarily because the expertise is not available in their country. So I treated someone from Canada a couple of weeks ago who was under the care of a great surgeon in Canada. But the problem is the waiting list and the horrible effect of COVID, etc. I see some patients from countries where the particular multidisciplinary team setup is not available. They may have a great surgeon working alone, but having an endometriosis surgeon that works with the urologist and the thoracic surgeon and a neurosurgeon, etc. That's something that some of my international patients come to me for.
Okay, and how can patients get in touch with you if they'd like to reach out to make an appointment?
Contacting my office is the best way. I mean, they can find my office details online. Website address is endometriosisconsultant.co.uk, and through there they can email the office or phone the office, and I often, for international patients, I usually do virtual appointments, and we'll try and do all the investigations that are necessary closer to home, and then get ourselves as close to a plan as possible before asking them to come over to be examined and for surgery if the surgery is required.
And for those based in the UK, do you work in the NHS and private?
Not anymore. I work privately only at the moment. So I left the NHS in March. I still help when help is needed, but at the moment I'm only private.
Okay, that's good to know. We'll put a link to your website in the description below the video. And thank you again so much for spending time with me today to answer our questions.
Not a problem. Thank you very much. It was a pleasure.
Thanks so much for watching. I hope you enjoyed the video and feel more equipped for whatever your next steps are. If you'd like to learn more about topics around recurrent or chronic UTI, be sure to check out our other videos or head over to liveUTIfree.com for in-depth articles. We'll also add some links in the description below for resources you can share with your doctor. Of course, if you like what we're doing with this channel, be sure to hit subscribe and check the bell so you'll be notified of our future videos. Thanks so much for watching, and until next time, keep asking questions and pushing for better solutions.